Now, there are many reasons for patients to have what's called hepatitis. So hepatitis is inflammation of the liver, and there it could be hepatitis A, B, C, and sometimes D. Now, and it could also have some other fatty liver diseases, but basically the liver is now not functioning well, and it can lead to other symptoms. So now there may be some engorgement on the right upper quadrant, so that we would feel some there, we would express some pain there, and then all of a sudden they may end up turning this color. It's a jaundice color. Now, this is an overaccumulation of what we call bilirubin, and we're unable to excrete this. Usually some of it's formed with bile and bile salts. That's how we get bilirubin. Some of it's then recycled and used for more production of red blood cells. But in this case, some of it's just floating around. So for a person that has told you that they have liver disease and this might be affected, then they may have this jaundice and yellowing of the skin. And here's another picture that's more of a yellowing to the entire body, and we can see now this abdomen is a lot more distended. This is of a male. We see some pectoral budding, like a gynecomastia. Male looks like it's a male breast formation. And then, but most likely, look at the belly there. It's quite large and distended. It's round. We would then note that this could be ascites and having a lot of excess fluid in there because of the, what we'd say, the backup engorgement from blood flow through the liver. All right. Now, this is another good picture slide of our ulcers that form. We can have the ulcers that form somewhere in the stomach. Then it can share it from the stomach down into the duodenum, and it can be in that transition part of that, or it could just be in the duodenum itself. Remember I told you that we can have these peptic ulcers that form in the stomach, and then other areas can start to wear away where we can have a lower GI bleed. So upper and lower GI bleed, the difference again is the upper GI bleed will cause more of a coffee ground type emesis, and as a result of it being digested with the gastric juices and the high acidic content, as it transits through the intestinal tract, the stool is more black, tarry like. When we have somebody that has a lower GI bleed somewhere way down in the duodenum, we notice that, and including the colon itself, we'll have more red blood streaked stool or just red blood per rectum because it's just leaking through and it's not being digested through the high acidic content of the stomach. Here they're showing you just a view from a camera that has been inserted into the abdomen, and they're showing you this is ulceration. It's just dark, it's not healthy, it's not red, it should be nice and pink and very red. This is just worn away and irritated and inflamed. Our abdominal aorta slide shows you here as the aorta descends from the arch as it comes out from the heart and out through the aortic valve. Blood flow continues down this aorta through the thoracic cage and down into the abdomen. What's missing is a few more of these protrusions of arteries coming off that aorta that would feed to the other organs under the diaphragm. But here we show that the arteries that are running out towards the kidney. So this aneurysm can happen anywhere. It can happen down there by the saddle where the iliacs are formed and then go down into the femorals. This one here is right in between the iliacs and the renal arteries. Now we can have an aneurysm above the renal arteries. Anyhow, as you can tell, once this ruptures, we're looking at lack of blood flow and poor distal pulses below the site of this aneurysm. So if they were higher up, we lose blood flow even to the kidneys, and so the person may have not peed for a while. Again, this is rip-roaring back pain, no position of comfort. It's sharp, it's intense. It's one of the worst pains that you've ever felt. 10 out of 10 on a pain scale. And if it starts to rupture and leak like this, we're probably going to see them in shock. And then possibly, if this isn't tamponaded or stopped, they'll leak out into the entire abdominal cavity, and we'll see a patient in cardiac arrest. That was the aneurysm. The dissection, again, is, as we see, this pressure is just tearing away at that inner lining, and then it's just going to shred right through. But we're looking at that media, tunica media, and as it gets further out, as far as the outer tunic, it's just a very thin lining, and it's going to allow that dissection to just rupture. Now, this is not the ballooning now. This is the irritation and rupturing and tearing away of those tunics because of the overpressure due to long-standing hypertension. Most patients will then double up and into this fetal position. They can be right or left, and we would call this a recumbent position, but knees to chest, more of this fetal position, as it lessens the amount of pressure that's put on the abdominal wall. So they quite often would want to draw their knees up, because then it loosens the tension of the abdominal muscles that ride over the anterior surface. Here we have the patient just gripping over their stomach, and because it's in the abdomen and they're feeling lousy, you're going to have other additional symptoms that share the common symptoms for all of these medical emergencies that happen in the abdomen, such as pale, cool, and clammy skin, increased heart rate. They may complain of nausea and vomiting. They may feel lightheaded. They may feel like they feel dizzy. So all of these are shared symptoms. We need to find out where. Now you're going to have to ask the patient to kind of get supine, lay them on their back in order to do a better exam. We're going to look, listen, and feel. You're going to focus just on the abdomen, but you're going to end up doing more of a head-to-toe exam later, as we need to find additional areas that might be involved. But you got to get them onto their back in order to do a good exam, and we have to expose those areas. So once we get them on their back, we're visualizing and we're looking for any type of scars, any type of bruising, any kind of outpouchings, any type of pulsations that are going on. And then when we're palpating, we're doing the 4 quadrants again, particularly paying really close attention to these areas. Here they're using that bimanual technique again. So one hand puts the pressure, the other hand feels. We can feel for pain or tenderness. We can feel for pulsatile masses for an aneurysm, and we're trying to just localize where this pain starts. So again, for our gallbladder and liver, it may be in that right upper quadrant. If it's for our appendicitis, it may start around periumbilical and then down into the right lower quadrant, the McBurney's point. If it's something more of a gallbladder and then pancreatitis, it may be like epigastric, and we have some referred pain to either right scapula, or it could go straight to the back. If it is a aneurysm, we may actually feel and be able to outline the aorta as it runs just slightly towards left off of midline. So we're going to palpate that very gently, as we don't want to irritate it and cause it to rupture. Again, other things we're looking for are surgical scars, and these may be just pot marks or marks because people have done maybe laparoscopic surgery, or there might be just general incisions that you could see where it's just kind of big scars right across the abdomen or in the lower pubic region. So be very inquisitive and ask a lot of questions as you're doing the focus exam. All right, follow up on your summary for abdominal pains.